So there I was, in Florida on vacation with my family. I'm in the emergency department. I'm nervous. I'm scared. I'm in another state. These are not my healthcare providers. Can they truly provide the care that I need? How will they gain access to my health information? Hello, everyone. I'm Shakeema Jordan, an ECU DNP FNP student, and today we're going to discuss Health Information Exchange. Health Information Exchange is a technology that electronically shares all clinical and administrative data throughout healthcare settings. There are three forms: direct exchange, query-based exchange, and consumer-mediated exchange. Direct exchange provides the ability to send secure information electronically between care providers. Query-based exchange provides the ability for providers to find and/or request information on a patient from other providers, and consumer-mediated exchange provide the ability for the consumers to control the use of their health information. Benefits of health information exchange are the ability to access and share a patient's vital medical history, facilitate care coordination and patient involvement, reduce duplicate treatments and costly mistakes, create a potential loop between research and actual practice, and to improve the speed, quality, safety, and cost of patient care. Barriers to health information exchange are privacy and confidentiality concerns, to accurately link the patient records, and to manage the complexity of patient consents. There are federal laws and policies evolving to alleviate some of those barriers. Two of those laws are the 2016 passage of the 21st Century Cures Act and the 2017 Substance Abuse and Mental Health Service Administration Final Rule. These two laws and others aim at improving privacy and security of patients' health information, to provide unique patient identifiers to help link patient records, to ensure that we're providing safe transfer of patients' health information across networks throughout the nation. Federal legislations are the 1996 Health Insurance Portability and Accountability Act, 1998 U.S. Department of Health and Human Services, and 2009 the North Health Information Technology for Economic and Clinical Health Act, which also included the National Coordinator for Health Information Technology, and the 2015 U.S. Food and Drug Administration. HIPAA aimed at preventing healthcare fraud and abuse, enforcing standards for health information, guaranteeing the security and privacy of health information, and ensuring that health insurance portability for employed persons. Barriers to this act was the process that it took and the amount of years to adopt the standards surrounding this act. The U.S. Department of Health and Human Services in 1999 proposed the privacy and security which were applicable to entities covered by HIPAA. This act looked at the standards for privacy of individually identifiable health information. It aimed at finding that balance between a patient's right to privacy and a provider's access to health information. Within 2002 to 2005, proposals to that act were implemented to include patient privacy rights, implementation of safeguards to protect the confidentiality, integrity, and availability of patient health information. Barriers to this act was the need to implement individuals such as policies and procedures, privacy officers, and provide education. HITECH in 2009 was the development and adoption and implementation of health information technology policies and standards. They aimed at enhancing privacy and security protections for patient information, providing providers access to patient information across the nation, promote prevention, early detection, and management of chronic diseases, improve public health and clinical research, reduce some of those health disparities, and provide incentives for providers to engage in meaningful use of health information technology. Barriers to this act was a lack of electronic health systems being utilized by healthcare organizations, and the association of that cost to implement those electronic health systems that healthcare organizations would have to bear. The U.S. Food and Drug Administration looked at the regulation of medical devices to ensure public safety. Barriers to this act that were common types of applications were not being able to be regulated because they were not considered as medical devices. From a state legislation, the 2015 North Carolina General Assembly, which created the North Carolina Health Exchange Authority and also included the North Carolina Information Exchange Advisory Board. The North Carolina General Assembly was created to oversee and be the administrators of the health information exchange networks in a manner to ensure compliance, information education, and the facilitation of interoperability with electronic health records. They were housed in North Carolina Department of Information Government Data Analytics Center. The North Carolina Health Authority Exchange, again, was created by North Carolina General Assembly, and they would provide North Carolina's healthcare system with the health information exchange technology infrastructure that would support real-time access, and they also provide the ability to exchange and analyze health information. They also managed the North Carolina Health Connects, which was a tool to link systems with health information exchange networks. And this North Carolina Health Connects mandated North Carolina licensed health providers to connect if they provide Medicaid services. A timeline for some of those mandates and deadlines were in June 2018, hospitals, physicians, physicians assistants, and nurse practitioners. June 2020, all other providers of Medicaid and state-funded services. In June 2021, dentists, ambulatory surgical centers, and psychiatrists. The North Carolina Advisory Board are a team of consultants, and their goal is to provide enhancements, administration, and improve the operations of the Health Information Network. Two recommendations I would like to recommend to improve health information exchange within North Carolina will be requirements for clinical health informaticists in both the public and private sectors. That is, bringing in our clinical health informaticists and having them as part of our team throughout healthcare organizations and agencies to establish some of those partnerships, to provide decision support, to improve workflows and access to care, to monitor networks and database securities, to help us develop those policies and procedures, ensure we're meeting the federal and state legislative standards, mandates, and deadlines, and to provide education, all enhancing the knowledge about health information exchange within our healthcare organizations and agencies. The second recommendation would be to enhance the patient participation. That is, bringing our patients to the table when we're making those decisions about health information exchange networks and applications, because not only does it impact our healthcare providers, it also impacts our patients. With that, we can build trust amongst our patients, incorporate the patient's perspectives into the work that we do to ensure we're providing a more patient-centered approach, to enhance the utilization for our patients, to help reduce some of those barriers around their privacy and confidentiality concerns, ensuring that the patient knows their rights and they're a part of some of those discussions, and also to increase patient satisfaction. Here are a list of our references. I want to thank you all for taking the opportunity to listen to this video recording regarding health information exchange, and I hope you have a great day.